Hello everyone, my name is Borbála Körmendy and I work for the ENT department of Bajcsy-Zsilinszky Hospital. Here you can see my project list. The first one on that list is investigating the validity of the POD6 staging system for staging congenital cholesteatoma. Congenital cholesteatoma is a dangerous disease in which a keratinous epithelial mass remains in the tympanic cavity during embryonic development. This can exist this is usually seen in the clinic as a keratinous pearl on the medial side of an intact tympanic membrane. And it can have almost no symptoms or very mild symptoms. This is why the mean age of diagnosis is only 5 years. But unfortunately, over time, this pearl has a tendency to expand, and thus it can lead to severe complications such as cranial nerve palsies, vertigo, and even meningitis. The POD6 staging system is the most widely used staging system for this congenital cholesteatomas, but there's no clear consensus on whether it's actually the best staging system that can be used for this disease. We feel that since it is a very rare disease, it's very important to have a reliable staging system in order to correctly gauge prognosis, plan surgeries, and compare the results on a multi-institutional and international level. Our aim is to answer the clinical question, does POD6 stage correctly predict the likelihood of residual disease? Our population is patients with congenital cholesteatoma. We are comparing the stages to each other, and our outcome is residual disease. Here you can see our search and selection process. We have found more than 6,000 articles that we have narrowed down to 7 that we have included into our meta-analysis. As a result of that, we ended up with this forest plot. If you look at the forest plot, you will see that the confidence intervals of the proportions in each stage is very wide. We have very low event numbers in all stages for the patients, and also the p-values are quite high. This led us to believe that currently, based on the already existing literature, we cannot assess a statistically significant difference between the stages of the POD6 staging system. This is largely due to the fact that, unfortunately, in our key articles, there is a very high risk of bias. You can see that all articles have failed in the domains of attrition bias and bias due to confounding, because they have failed to define and name any confounding factors, such as different surgical methods that were potentially used for treating the congenital cholesteatoma. And also, unfortunately, they did not seem to make any efforts to try and reconnect with the patients who were lost to follow-up, and they didn't really give us any information on why these patients were lost to follow-up. You can especially see this in our hearing outcomes. This is the varied reporting that we were dealing with. On the left side, you can see the articles that reported on hearing outcomes, and on the right side, you can see the thresholds that they have examined during audiometric examinations. And you can see that all of them use slightly different thresholds to calculate their values, and none of them use the thresholds that were included in the Committee on Hearing and Equilibrium guidelines. One of the outcomes that matched the already existing literature results in the literature was the location of cholesteatoma, which is defined as the quadrant of the tympanic membrane through which the keratinous pearl that I have talked about earlier can be seen in the outpatient clinic. The literature says that it's most frequently the anterior superior quadrant, and this is also what we have found. It was the same as mean age at staging. The literature that we have seen so far has shown that older patients tend to have a higher stage of disease because of the expansion of the keratinous pearl, and this is also what we have found based on our key articles. The strength of our analysis is that this is the highest level of evidence that currently exists about the POD6 staging system, and unfortunately our evidence level is limited by inconsistent and deficient reporting in our key articles. The implication for research is that more cases with carefully documented follow-up data is needed to be published. And the implication for practice is that although second look operations should not be omitted in early stages, the staging system can be used to gauge other outcomes. So our overall conclusion is that we cannot properly assess the prognostic value of the staging system based on the existing literature. We have made quite a bit of progress with our manuscript writing process. We are hoping to submit it in a few days to the Laryngoscope, which is a Q1D1 journal. My second project is very, very similar to the first one, except for at this time we are looking for a different staging system, the European-Japanese staging system, which can be used for all types of cholesteatomas. Congenital cholesteatoma is very, very rare, but there's another type of cholesteatoma called retraction type cholesteatoma, retraction pocket cholesteatoma, in which a tiny part of the tympanic membrane is kind of sucked into the tympanic cavity and the keratinous pearl forms in there. Many staging systems exist for all types of cholesteatomas. One of the most recently published ones is the European-Japanese staging systems, and many studies have looked at how it does with estimating disease severity, but none of these articles came out with positive results. We feel that uniform definitions for staging are very important, and our aim here was to assess the usefulness of this European-Japanese staging system for cholesteatomas. Here, our population was all patients with all kinds of cholesteatomas. We are also comparing the stages to each other, and our outcome was recidivism, which was defined in the paper in which the European-Japanese staging system was published as the summarization of recurrent disease and residual disease. Our secondary outcome is hearing improvement, and our null hypothesis is that European-Japanese stage predicts outcomes correctly. We have made quite some progress with this project as well, but unfortunately we are still waiting for the raw data that we need to be able to do our analysis, because the correct amount of individual patient data was not published in our key articles. My third project is investigating the applicability of fat graft myringoplasty. The fat graft myringoplasty is the most inexpensive, easiest to learn, and quickest method for covering up perforations in the tympanic membrane. There is almost limitless grafting material in the human body for a fat graft myringoplasty, and a few resources are required. This procedure can also be done in the outpatient clinic. It has already been proven effective for smaller perforations, but currently no guideline or recommendation exists for using this procedure or using it for bigger perforations. This will be a collaboration between Semmelweis University's Clinic of Otorhinolaryngology and Bajcsy-Zsilinszky Hospital's Department of Otorhinolaryngology. Again, here you can see my projects, and thank you very much for your attention.
Thank you for your impressive presentation. And I would like to know what is the implication for research from your first project, since you found so much bias in the studies, what you do different and what you think it's needed from now on.
Okay, so our first project ended up being a lot more provocative than we thought. We thought that there were going to be some, exact results, but the results seem to be that there needs to be a systematic change in how results of middle ear surgery are reported on. Because one of the key messages that we are hoping to communicate with our article is that people need to take bias into consideration. I don't think that any of these articles I don't think that any of them published false results, but I definitely think that in order for us to be able to create higher levels of evidence, reporting needs to be more diligent and more punctual about these patients. So basically what we are saying is that we need more data on follow-up, and we need uniformized methods of surgery for treating cholesteatoma, and also they need to be followed up in a uniform way.
How good data do we have on cholesteatoma in Hungary? So what is the quality of the data? Can you gather a good piece of data from the Hungarian healthcare database? Is it
Okay, so
possible or
cholesteatoma?
impossible mission?
My supervisor has contributed to the Hungarian literature on cholesteatoma in a substantial way, but unfortunately, since Hungary is a small country and especially congenital cholesteatoma, but all cholesteatomas are quite rare, unfortunately, we don't have studies that would have large population sizes. So in our clinic, we see around 100 of all cholesteatomas and in a year, and maybe one congenital cholesteatoma in an entire year. And we are an otological surgery center, so we have quite a few patients coming in.
Okay, thank you.